Well, good morning. Chris Pannucci here at Plastic Surgery Northwest in Spokane, Washington. Thanks very much to the Spring Meeting for the opportunity to talk about something near and dear to my heart, blood clot prevention amongst the abdominoplasty and aesthetic population. In terms of disclosures, I have recently completed a completely unrelated study funded by Mentor and by extension Johnson & Johnson, and also sit on the editorial board of the Aesthetic Surgery Journal. Now, I recently gave grand rounds at the University of California, San Diego, and they were kind enough to create this wonderful meme. While I don't necessarily agree with everything on here, I think it's important to understand that we are battling thousands of years of evolution. Blood clotting is a natural phenomenon, and it behooves us to understand how do blood clots form, why do they form, and how can we mitigate or decrease that risk in our patients. My central point today is that there are multiple opportunities, and I will keep coming back to the CME article from the ASJ in 2019. There are multiple opportunities in your patient's care pathway to identify, modify, but unfortunately probably never completely eliminate risk for venous thromboembolism. In the preoperative setting, I think that there are many things that you can do, and these are concepts and ideas that you can incorporate at your initial meeting with that patient. Thinking about my patient, this is a patient who came to me to talk about abdominoplasty, and as I met with her, I found that she was 44 years old. She had a slightly elevated body mass index, she had 3 children but had never lost a pregnancy, and she had no outside estrogen sources in her everyday life. In addition, she had no personal or family history of blood clots in the legs or lungs. Now, for this patient, I got this information 2 ways. One of those ways is to discuss with the patient during our initial face-to-face visit. But in addition, our preemptive data capture form that we provide to patients to bring to their visit has an entire column with common risk factors for blood clots in the legs or lungs, allowing us a second level for that screening to doubly ask about this very important patient safety issue. For this patient, I chose to complete a 2005 Caprini score. And for this patient, we identified that she had no modifiable risk factors. She only had age, obesity, and the need for a major surgery over 45 minutes. So thinking about baseline risk, for the general patient, I am usually quoting data from Winnicor and colleagues out of Cosmetisure, 130,000 aesthetic surgery patients. Amongst the abdominoplasty patients in this group, the risk for clots at 30 days was 1 in 500, or 0.2%. Now, preemptively considering your patient's risk, doing this not in the pre-op area, not in the PACU, but actually at your initial contact with the patient, allows you to identify risk factors that are potentially modifiable. For example, if you find someone who recently had a surgical procedure or is currently taking an estrogen product, you can move their surgery out farther, you can hold that oral contraceptive. If you find someone who has lost multiple pregnancies or has a personal or family history of clot, you potentially can work them up further. And understanding someone's baseline risk level, you can also have a more informed discussion with them about the role of combining procedures and a longer OR time. Better for patient convenience, a single recovery, but potentially increasing their risk. Ultimately, this process allows you to identify and modify risk factors when possible, decrease but never eliminate your patient's risk for clot, and also improve that informed consent process. In the preemptive or preoperative setting, I'm always discussing with patients the role of additional procedures. What if we add a second procedure to an abdominoplasty? Well, wonderful data from Winnicor and colleagues show that yes, adding an additional procedure increases your risk by a factor of 5. But to be fair, the aggregate actual risk increase is 0.16% at 30 days. If you look at the role of 1 versus 4 procedures, you see there is a essentially logarithmic and less linear relationship between total number of procedures and risk. But even doing 4 simultaneous procedures, your risk only goes as high in the general aesthetic population as 1 in 200 or 0.5%. Now, intraoperatively, there are things that you can be doing. When you are considering your anesthetic type, not everyone has access to a non-general anesthetic, but if you do, avoiding a general anesthetic is known to decrease risk for clots. I am a big fan of intermittent pneumatic compression because these work in 2 ways. One is by physically propelling blood out of the legs to minimize stasis, And two, even a single sequential compression device will activate the local fibrinolytic system and increase those blood-borne fibrinolytic factors. So a single SCD can have a head-to-toe effect. There are wonderful data in surgical patients as a whole from Ho and colleagues that clearly demonstrate sequential compression devices decrease risk for deep vein thrombosis in the overall surgical population. Coming back to these data from Winocor, you have already used these data to talk with your patient about the role of multiple procedures. But for patients who may be having a more important procedure to them and then an add-on less important procedure, you can also talk with them that says, listen, I'm going to watch the clock. If the day is running long, I might choose not to do that final procedure that maybe is less important to you. And we talked about these data already. Now, thinking about plication. Plication represents a potentially modifiable risk factor, and there are wonderful data both from the abdominoplasty population and the breast reconstruction with tram flap population that shows that plication significantly increases intra-abdominal pressure. Now, it does so because your abdominal contents are a fixed volume, and plication decreases the space in which they can exist. By definition, that will drive up the pressure. And we know that for the abdominoplasty population, that can go up by 6 millimeters of mercury. Now, wonderful work from Arash Momeni and colleagues. Arash is on faculty at Stanford, has shown in the breast reconstruction population that a tighter fascial closure not only increases intra-abdominal pressure, but also produces common femoral vein stasis, where the flow in the common femoral vein is decreased for at least that first day after surgery. So this is my patient, and you can see, or with the triangles down below, I actually started her in the prone first position in order to allow me to do a direct excision posteriorly and do some posterior and lateral flank liposuction as well, turning her over to then complete the resection, and I did do plication for this patient. And ultimately, yes, the prone first approach is a longer time in the operating room, but that approach balanced the patient's goals while still having an acceptable risk profile after an extensive discussion between she and I. Now in the PACU, certainly early ambulation and avoiding dehydration can decrease vascular sludging, lower extremity venous stasis, and allow the patient's calf muscle pump to take over and start moving that blood on its own. Intermittent pneumatic compression in patients who are not fully awake can help with that as well. There's wonderful data from Clayman and colleagues looking at the potential downsides of compression garments. And they specifically show the compression garments on the thigh that are too tight can actually impede venous egress from the lower extremity. And they show this by, after the garment is applied, the popliteal vein is dilated, meaning that an inappropriately applied garment can create lower extremity venous stasis, one of the known factors in Virchow's triad. Now, I don't want you to think that I'm being negative about some of these maneuvers. For my patient, I definitely plicated her, and I definitely used a garment because I felt that that helped her to achieve the results that she wanted to get to. I think that, again, I am not advocating not to use these techniques. I am advocating that you think about the potential risks and benefits of these interventions as you not only talk with a patient before surgery, but also as you make some of those decisions intra and post-operatively. Now, thinking about after surgery, we've already talked about the role of early ambulation. We've already talked about the importance of avoiding dehydration. I want to talk specifically about anticoagulation because it's probably the #1 thing that patients and surgeons ask me about. What I can be very clear with is in the plastic surgery population in specific and in the surgical population as a whole, there are excellent clinical trial and meta-analysis data that supports only patients with Caprini greater than or equal to 7 who are admitted after surgery benefit from postoperative anticoagulation. And by benefit, I mean there is a clear reduction in VTE risk with an acceptable potential increase in bleeding. Now, to be fair, there are only inpatient data available on this question. So here is my summary slide of the clinical trials data for blood thinners in aesthetics. And you will notice that it is blank because with the exception of one aborted randomized controlled trial that tried to look at the role of rivaroxaban in the abdominoplasty population. This is one of the newer DOACs. This was aborted at patient 27 due to 8 of 27 patients, all of whom were in the blood thinner group bleeding. There are no other randomized controlled data on this topic. But I teach a course on this vein regularly, including at the national meeting. And at least one surgeon after every time I teach this course comes up and tells me, listen, I don't want to do individual risk stratification. I don't want to worry about patient level factors. So instead, I give an anticoagulant to everyone. And fine, that may be your practice. I think it's important to consider, is it safe? Is it effective? Are you doing it solely to decrease your liability? So Joe Hunstad has probably the largest series looking at routine anticoagulation in the abdominoplasty patients, giving 600 consecutive abdominoplasty patients a DOAC. This is a oral 10A inhibitor that they were starting at a prophylactic dose for a week, starting 12 hours after the operating room. I think it's important to understand that with this fairly aggressive protocol in what we would envision being a low-risk population, their risk for clots was 0.7%. Their risk for bleeding was 2.2%. These are non-controlled data. There is no evidence here that this practice decreases risk for clots. And you can think of your own practice. Do you expect a 2.2% risk of bleeding if you are not routinely anticoagulating? Data from Denise Jarlahati and Herlef Lund out of St. Louis did show that in the body contouring population, fondaparinux can significantly decrease risk for VTE without significantly increased reoperative bleeding. These results, to my knowledge, this was not a controlled study, this was a pre-post study, but these have never been repeated to my knowledge. People always say, well, listen, you know the data better than anyone, what do you think? And I always go back to these data. Yes, these are data from rhinoplasty population, but they were looking at the baseline Caprini score of 412 rhinoplasty patients, showing that only 2% of rhinoplasty patients met that baseline Caprini cut point of 7 or higher, where chemical prophylaxis has been shown to be effective. And I've even written, in response to that article, a letter to the editor, and I think that the title of this clearly shows where I stand on this, at least in 2017. But even today, I'm interested in this. And so these are emerging data of my own patients looking at the role of Caprini risk stratification in the augmentation population. To date, I have done 2005 Caprini scores using a face-to-face interaction on 90 consecutive patients presenting for breast augmentation. And what you're seeing here, very similar to the rhinoplasty data, the overwhelming majority of the aesthetic breast augmentation population is at low risk for clots. So, in summary, first of all, I really appreciate the opportunity to talk about a topic near and dear to my heart that drastically impacts the safety of our patients. I want everyone to understand that there are multiple opportunities to identify, modify, decrease, but probably never eliminate risk for clots in the abdominoplasty population. Specific to my patient who had a Caprini score of 4, in the preoperative setting, I did not identify any risk factors that I could modify. We talked about a single operative procedure. Intraoperative, I did use a general anesthetic with sequential compression devices and a prone first approach. I did plicate her. I did use a garment. The surgery was just over 5 hours, and she had 350 cc's of urine. In the PACU, an additional 250 cc's of urine. Continued the SCDs until she was able to ambulate. And after discharge, only ambulation and good hydration. I did not prescribe her any blood thinner after surgery. I really appreciate the opportunity to give this talk. Looking forward to your live questions in just a moment. Please feel free to reach out with your questions at my contact information here. Thanks so much.